Good evening, everyone. Let's begin with this session of mini test series. In medicine, we will be covering these topics: cardiovascular system, GIT, respiratory system, and acid-base or some general medicine questions. Let's start with the questions. So these are high-yielding questions, means ki these topic will be high-yielding topics, important topics. Let's see. Question number 1. Patient present with diarrhea and weight loss. There is foul smelling stools and lost 5 kgs weight. There is no blood in the stools. So these are the lab tests which shows that hemoglobin is low. MCV is 70. 70 MCV means ki it is low MCV. 80 to 100 is normal value. Serum ferritin is also low. Normal serum ferritin is 20 to 200. This is a normal value. So iron deficiency is present here. Anti-TTG antibody is positive, IgA type. So which is the most appropriate test to confirm the diagnosis of a celiac disease? So the diagnosis is suspected celiac disease based on the TTG antibody. So confirmatory test for celiac sprue is a small intestinal biopsy. And that will show the characteristic finding of loss of villi along with a lymphocytic infiltration. While the first test, genetic test for HLA, DQ2 and DQ8, though they are seen in 100% patients of celiac sprue, they are positive, 100% patients. But these will not confirm the diagnosis because these are non-specific and they are costly, so it will not be the choice. Colonoscopy with the biopsy, colonic biopsy is usually done in cases of inflammatory diseases or cancers, but as such, no evidence because there is no blood in the stools, so that will not be appropriate. Stool study for infectious pathogens, so infection for 1 year is highly unlikely. So the best answer here will be small intestinal biopsy with upper GI endoscopy. And these parameters are low because predominantly proximal small intestine is affected in cases of celiac sprue. So there will be a deficiency of all the elements which are absorbed from the proximal part like iron, folic acid, calcium, magnesium, copper. They will be deficient, including fat. So answer is C option. And celiac disease is one of the topic which is frequently asked. Now moving on to the question number 2. So question number 2 is patient has 6-month history of pain, diarrhea, blood in the stools. There is weight loss and feeling feverish at times. Elevated CRP and ESR is noted here. So based on this clinical history and investigations, the disease which is ruled out is irritable bowel disease. So irritable bowel disease or irritable bowel syndrome, because this does not have any blood in the stool, there is no elevation of CRP or ESR, inflammatory markers will not be there, no weight loss will be there. So we are left with 3 options. Infectious colitis. Infectious colitis, 6-month history is unlikely. So we have to choose from ulcerative colitis and Crohn's disease. That will be decided on the basis of biopsy. So let's see which part is affected. Terminal ileum and colon is affected with some areas of normal mucosa in between, transmural inflammation and granulomas. So presence of transmural inflammation is the highlighting point and granuloma is the highlighting point. So that will differentiate Crohn's from the ulcerative colitis. So it is ulcerative Crohn's disease. In ulcerative colitis, number 1 is small intestine is not affected. So it is basically the rectum or rectosigmoid which is affected, as well as it is a continuous lesions which are present, and it is mucosal inflammation. and there are no granulomas. So this clear-cut differentiate ulcerative colitis from the Crohn's disease. Yes, skip lesions is seen in cases of Crohn's disease. Here it is a continuous lesion which is present here. And also for your questions, the keyword for ulcerative colitis will be this keyword, tenesmus. While for Crohn's disease, the keyword will be fistula formations. Fistula formation, and because of the small intestine involvement, we will have malabsorption present in Crohn's disease. So these will these clinical features will differentiate Crohn's from the ulcerative colitis, these keywords. So answer here will be Crohn's disease. B will be the correct answer here. Now, inflammatory bowel disease, again, this is one of the last moment revision topic for your NEET PG exam. One question guaranteed you will get from inflammatory bowel disease. Now, let's come to the question number 3. So question number 3 is on the analysis of jaundice. So let me see how many of you can identify this cause which is given here. Pseudopolyps in ulcerative colitis, remember Dr. Vineet, pseudopolyps are double plus in ulcerative but single plus in Crohn's. So that is not a good difference because it is more common in UC but also seen in Crohn's disease. So that will not differentiate. Why not A in the first question? Because the A option is non-specific, means it will be present in other patients who are not having celiac disease. So you have to diagnose it with a specific test, that will be biopsy. That will be with biopsy. Now, coming to this patient has jaundice and the total bilirubin is given as 4 and direct bilirubin is 3.2. So this is a case of elevation of isolated elevation of direct bilirubin. Direct bilirubin, because liver enzymes are absolutely normal. These are all normal liver enzymes. Now, direct bilirubin elevation can be seen in Duane-Johnson syndrome, can be seen in Rotor syndrome. So how to differentiate them? A and B option, they present with elevation of indirect bilirubin. So to differentiate them is the urinary level of coproporphyrins. So in cases of Duane-Johnson syndrome, there are 2 isomers of coproporphyrin, 1 and 3. So normally 3 is more prominent than 1. But in cases of Duane-Johnson syndrome, the coproporphyrin isomer 1 will be more than 80% of total urine coproporphyrin. While in cases of Rotor syndrome, isomer 1 will be less than 70% of total urine coproporphyrin. So that will differentiate. The prominence of coproporphyrin 1 will go in favor of a Duane-Johnson syndrome. While other feature of Duane-Johnson syndrome is it is also known as a black liver, because epinephrine metabolites are excreted by the MRP2, which is deficient in Duane-Johnson syndrome. So MRP2 excrete epinephrine metabolites, so they will accumulate in the liver, and those metabolites are black in color. So it is known as black liver. While as such, no deposits or pigments are seen in cases of Rotor syndrome. So this will go in favor of a Duane-Johnson syndrome. Now, moving on to question number 4. So, question number 4 is a 45-year-old man presents for a routine checkup, and as a part of workup, hepatitis B serology is performed. So, these are the serologies which are present here. Which is the most likely interpretation of these serological finding. So acute hepatitis B infection. Acute hepatitis B infection will have virus present in the body. Virus is HBs antigen. This is virus. Along with that, we will have IgM, anti-HBC. While chronic hepatitis B will have HBs antigen. Along with that, IgG, anti-HBC. So virus should be present if it is an acute or chronic infection. HBs antigen represent the virus. Now resolved past hepatitis B infection. So in resolved, that means ki virus is gone out of the body. So it will be HBs antigen negative condition. And evidence of a past infection, natural infection, will be represented by IgG, anti-HBC. Mandatory. And plus minus, there can be anti-HBs also. So this parameter goes in favor of a resolved past infection, means infection has occurred in the remote past. While immunity due to hepatitis B vaccine will have anti-HBs only. It will have only HBs because we give a surface antigen subunit to induce the immunity in the patient. So patient serological profile has only HBs antigen positivity, while surface antigen negative and anti-HBC negative means ki there is no exposure to virus, to the virus. And again, serology of hepatitis B. Serology of the hepatitis B is a mandatory topic to be done for your exam. Again, I will give you guarantee one question will always be there from hepatitis B serology. Now, what about the window period? So in cases of the window period, the serology will be, so if we write the window period, so remember this point, window period is a period of acute infection. Means it will have IgM anti-HBC here. HBs antigen will be negative and its antibody will also be negative. So this is window period for hepatitis B. Hepatitis B. Recovery phase. So resolved infection is recovery phase. Recovered infection is resolved past hepatitis B infection only. Hepatitis B infection only. Anti-HBC negative, specific for. So specific for. So question is not clear. So these are the. So the correct answer here will be D option. Immunity due to hepatitis B vaccination. Now coming to the question from my side. Let me see who will give me the question answer. Tell me, for pre-core mutant, for a pre-core mutant, so pre-core mutant, what will be the serology? Pre-core mutant, remember, is chronic infection. Pre-core mutant is a chronic infection. So you will get the serology of HBs antigen positive as well as IgG anti-HBC. That will be positive. That will be positive. And but here the HBe antigen will be negative and HBV DNA will be elevated. So this is the serology of pre-core mutant. Pre-core mutant, E antigen negative and DNA will be positive. DNA will be positive. Yes, correct. Now coming to the next one. So next is question on the ascites. So these ascites questions are very simple. These are very simple questions. You have to just follow a flow chart. So the flow chart is number one step is SAAG, serum albumin ascites gradient. That will be less than 1.1 or more than equal to 1.1. Means serum albumin minus ascitic albumin Remember these words very carefully. And this more than 1.1 means कि ascites is due to high sinusoidal pressures like portal hypertension related causes. So you have to look at ascites, total protein. What to mark if only anti-HBs IgM is given, but window period is not given as the option. So then you have to see surface antigen. If its surface antigen is there, and then it is acute infection. Acute infection. In Puru mutant, can IgM anti-HBc be positive? No, it will be IgG because it is a chronic infection. Chronic infection. So ascites total proteins will be assessed. So if this total protein is less than 2.5 grams per deciliter, so it is a case of cirrhosis. And if it is more than 2.5, then it will be a case of post-sinusoidal cause. Like for example, CHF or Budd-Chiari syndrome. CHF or Budd-Chiari syndrome. So understand this point कि albumin is different and total protein is different. And when it is less than 1.1, so it can be either due to a low serum albumin or it can be because of high ascites albumin, like inflammatory diseases. And low albumin will be nephrotic syndrome. And also understand this point. SAAG is not for exudative or transudative difference. Remember this point. SAG is never for exudative or transudative differences. It is just whether the cause was high sinusoidal pressure or the cause was without high sinusoidal pressures. So never use a transudative or exudative in the ascitic fluid. Maximum students do this mistake. So it is not for exudative or transudative differences. It is only for when it is more than 1.1, means high sinusoidal pressures are there, liver related causes are there. Now let's put these values in the flow chart. So serum albumin is 3.2 and ascitic fluid albumin is 1. So SAAG is coming out to be here 2.2. 2.2 means it is more than 1.1. So this is a scenario here, SAG. Now look at the ascitic total proteins. Ascitic total protein is 1.5 means less than 2.5. So the correct answer is cirrhosis. So just put the variable in the flow chart like a mathematics and you will get 100% correct answer. So answer is A option here. That is the correct answer. Now, yes, it will be a case of a Budd-Chiari syndrome. Post-sinusoidal means कि it is CHF, Budd-Chiari syndrome. Now, coming to question number 6. So question number 6 is on respiratory system. Patient presents to the pulmonology clinic with 6-month history of dyspnea, non-productive cough. There is no history of smoking. Medical history is significant for rheumatoid arthritis. And these are the pulmonary function tests which are given here. So how to approach such questions? So always follow the flow chart. So the first thing which you have to assess is the ratio, FEVN upon FVC ratio. So if this comes out to be low, low means less than 80% of predicted value. %80 of the predicted value is low and normal. Predicted value means normal standard value for that age and gender. And then look at the value of FVC, FVC. So look at the value. So the FVC value if it came out to be normal or low, normal or low. This will be the scenario. This will be the scenario. So FVC is normal if the ratio is low and FVC is normal. So this will be a case of a obstructive pattern. This is obstructive. And if both the parameters are low, so it will be a case of mixed. Mixed means obstructive and restrictive. Obstructive and restrictive. While if the ratio is normal, FVC is normal, so that means ki it is a pulmonary vascular disease. Pulmonary vascular disease or a healthy individual. And when the ratio is normal, FVC is low, this is a restrictive disease. This is a restrictive pulmonary disease. So let's first put those values in the flow chart. So first look at the ratio. The ratio is 90%. So remember 90% is not low. It is normal. Anything which is more than 80% is considered as normal. So it is normal ratio here. Now, let's look at the isolated value of FVC. So isolated value of FVC is 60%. So 60% means it is low. It is low. So 100% your answer will be it is a case of a restrictive disease, and the cause of the restrictive disease out of these options which are given here is interstitial lung disease. So interstitial lung disease will be the correct answer. Pulmonary vascular disease include like pulmonary hypertension or pulmonary embolism. Pulmonary embolism. Also, DLCO is low, and DLCO is low in cases of interstitial lung diseases. So just keep the things simple and use these flow charts. You will never get the wrong answer. Now, moving on to question number 7. All right. So question number 7 is patient present with fever, cough, shortness of breath. And there are bronchial breath sounds which are present at the right infrascapular area. So most likely it is a case of a pneumonia with consolidation. Now these parameters are given. So let's see what is the question asking. Question is asking ki curve score. So there are two things ki what is the curve score and what is the appropriate level of care in this patient. So the curve score is C stand for confusion. So confusion will be given as 1 point. But here the patient is alert. So there is no confusion. Then look at the U. U means ki blood urea nitrogen more than 20. So that will be given as 1 point. Here the blood urea nitrogen is 25. So 1 point is here. Now R. R means respiratory rate. So respiratory rate is increased here 30 breaths per minute. So it should be more than 30 respiratory rate. So it is given as 1 point. Yes, we'll take 1 point for here also. Even if it is 30, then take it as 1 point. While B stand for either systolic BP less than 90 and or diastolic BP less than 60. Any one of them, 1 point. And 65 is age more than 65. 1 point. So patient is having 70 years of age. So the answer here will be curve score will be 4 here, and the patient will need ICU care. So what is the curve score and the site of care? Curve score is 0 OPD, 1 and 2 IPD, more than equal to 3 is ICU. Is ICU. Urea 40. So Dr. Sweetie, here look at the words carefully. This is blood urea nitrogen, not urea. So what is blood urea nitrogen? Blood urea nitrogen is urea divided by 2. So it is same. It is same. No, blood urea nitrogen is different. Urea is different. So understand this point. So as a medical student, you should not be doing this mistake. You should not be doing this mistake. So it is half of the urea value. So answer is D option. Answer is D. And these are the area where mistakes happen. Even if you know the things, you know the topic, you know the concept, still without reading the question carefully, there is a chance that your answer will be wrong. Now come to question number 8. Question is patient have a right-sided pleural effusion, and these are the findings which are given of clinical examination. Now, diagnostic pleural test is done. So, question is which of the following is the most likely type of pleural effusion based on this results. So we have to check whether it is a transudative or exudative effusion. So lights criteria will be used here, and for the lights criteria, in a question the BP is 100 by 60. So remember what I have told you, that systolic BP less than 90 and or diastolic BP less than 60. So any one of them, so this is equal, any one of them is low, give 1 point. Even if systolic BP is 100 but diastolic BP is low na, so that will be given 1 point. Yes. So again, read this word carefully, and or. Now come to the next one, pleural effusion. So lights criteria. So the lights criteria will be used here. The lights criteria, number 1 criteria is pleural fluid protein divided by serum protein. It will be more than 0.5, or pleural fluid LDH divided by serum LDH more than 0.6. So, or pleural fluid LDH more than 2/3 of upper normal limit of serum LDH. Any one of them, these criteria is the lights criteria. So if we put those in the value, like pleural fluid protein is 2.4 and serum protein is 6. So this will come out to be, if we calculate, the value will come out to be, I think, 0.4. It will be coming to 0.4, I think. And pleural fluid LDH is 100, serum LDH is 200. So this will come out to be 0.5. So which is the cause here? So it should be more than 0.5, but here our value is 0.4. And here it should be more than 0.6. Here our value is 0.5. So it is not satisfying the exudative criteria. So it is a case of a transudative pleural effusion, and it is due to the congestive heart failure, because these options are exudative, including chylothorax. Chylothorax is also exudative. It is coming out to be exudative. Chylothorax, and here the answer will be pleural effusion, transudative in nature, and indeed this is the most common cause of pleural effusion overall. Most common cause. Now move to question number 9. So question number 9 is on the, now we move to the cardiovascular system. Patient has intermittent Canon A waves in JVP. What is the most likely explanation for these findings? So atrial fibrillation. Atrial fibrillation is A wave is absent, while junction rhythm has Canon A waves, and these Canon A waves, they are regularly coming with a rate of 40 to 60. So 40 to 60 is per minute. Third point of lights criteria is pleural fluid LDH more than 2/3 of the upper normal limit of the serum LDH. That is the lights criteria. While complete heart block, Canon A wave will be present here, but those will be intermittent. Intermittent means that they will be coming occasionally. They will be coming occasionally. While PSVT has Canon A wave, yes, this is a cause of Canon A wave. These are regular coming, and the rate here will be more than 100. More than 100. So intermittent means coming occasionally. Answer is C option. Answer is C. Now, coming to question number 10. So this is the murmur diagram which is given to you, and these days murmur diagrams are given. Questions on murmurs are frequently coming. So let's see which is this type of the murmur which is present here. So this murmur, as you can see, is coming between diastolic phase, between just starting at S2. So this murmur is early diastolic murmur. This is early diastolic. Early diastolic murmur is seen only in two conditions. One is AR, but the site of AR murmur will be left third intercostal space, which is also known as Ups area. And second is PR. PR murmur will be heard at the left second intercostal space, which is known as pulmonary area. Pulmonary area. Only two causes of this murmur is present. So the answer here will be aortic regurgitation. And in mitral regurgitation or tricuspid regurgitation, the murmur is this murmur. S1, S2, like this. So this is a pan-systolic murmur. Pan-systolic. Though MR can have various etiologies like acute MR, chronic MR, or MVP-induced MR. But whenever MR is given, assume, if nothing is mentioned, assume MR to be chronic. Assume MR is chronic MR when nothing is given. So that will be a pan-systolic murmur. Pan-systolic murmur. Now, so the area here is in the question, clear cut it is given that left third intercostal space is mentioned here. So it will be the Ups area. Now, moving on to the next question, question number 11. Okay, let me see who have has done this question correctly. What ECG feature will suggest right coronary artery thrombosis? So one by one, let's see the option and see. A right coronary artery supply which part of the heart? So the right coronary artery, it supplies SA node. It supplies AV node. It supplies inferior wall. It supply right ventricle wall. So the ECG changes which will be present here. SA node is affected. ECG change here will be either sinus bradycardia or sinus arrest. AV node is affected, we will get AV blocks. Inferior wall is affected, we will have ST elevation, which will be seen in inferior leads, lead 2, lead 3, and AVF with reciprocal ST depression in 1 and AVL. 1 and AVL. While right ventricle wall will have right-sided leads ST elevation like RV3, RV4 or RV5. So these are right-sided chest leads. ST elevation will be seen, and the most sensitive lead out of these three is RV4. RV4. So these will be the changes which will be present in a right coronary artery thrombosis. A option, ST depression in V1 to V4. This will be suggestive of non-ST elevation MI or unstable angina of septal and anterior wall. And that is supplied by LAD. That is supplied by the left anterior descending artery. AV block, yes, that is correct answer. 1 and AVL is representing the lateral wall, and lateral wall is supplied by left circumflex artery. Left circumflex artery. Then D option, ST elevation in V3 and V4. So V3 and V4, they represent anterior wall. And anterior wall is supplied by left anterior descending artery. Yes, A option can be reciprocal changes of the posterior wall MI. So it can be posterior wall MI reciprocal changes. Why not? Yes, there is a possibility. There is a possibility. It can be a reciprocal change. So we have to check posterior wall leads. Posterior wall leads. So, but posterior wall, it is supplied by which artery? It is supplied by left circumflex artery in most of the people. Most of the people. So, yeah, then even then it is not the correct answer. It is not the correct answer then. So the answer here will be B option. Now, coming to question number 12. Question number 12 is the ECG based question on the arrhythmia. So question is, which conduction abnormality does this ECG shows? So this conduction abnormality, if we look here, grossly there is some sort of a bradycardia which is happening. So in the bradycardia, you should look at the QRS complex first. So the QRS complex, if it is normal or wide. If it is wide, then it is likely third degree AV block. No doubt about it. If it is wide. If it is normal, look at the P wave. So P wave, if absent, it is a case of sinus arrest. And if P wave is present, then look at each P followed by QRS. So each P followed by QRS, answer is no. Then it is second degree block. And if it is yes, it can be a sinus bradycardia or first degree AV block. First degree AV block. So let me see what answer I am getting. I am getting the C answer correctly here. So in this, look at the QRS. So QRS is normal. I will go according to the flow chart. Then look at, are P wave present? Yes, this is the P wave. This is a P wave, P and P wave. T wave. T is taller than the P wave. This is a T wave. This is taller than P wave, which is happening here. So P wave is present. Yes, I will mark it. It is present here. Then I will assess, is each P followed by QRS? No. The third P fourth P wave is not followed by QRS. So this is a case of a second degree AV block. Now, I have to assess whether it is MOBIS type 1 or MOBIS type 2. In MOBIS type 1, there is a variable PR interval. And in a MOBIS type 2, it is a fixed PR interval. Fixed PR interval. So PR interval here, you can just see this horizontal line. So every time it is same, it is approximately 4 mm each, 4 mm. PR interval is fixed. And when the PR interval is fixed, it goes in favor of a Mobis type 2 second degree type of block. So examiner usually asks simple diagrams. They will not ask any exceptional or very tough diagrams. So do attempt these questions. You will be able to solve them correctly. Now moving on to the next one. Question number 13. So question number 13 is which of the following patient is a suitable candidate for an implantable cardioverter defibrillator? So ICD device, they detect the arrhythmia and then they deliver the DC shock to prevent the death. So what are the indications? So indications are, look at the A option. Polymorphic ventricle tachycardia occurring after cocaine use. So the indication will be idiopathic polymorphic tachycardia. If there is a known cause, then it is not indicated because we have to correct the known cause. But if it is idiopathic, so it can come back again. So idiopathic, polymorphic or any ventricle arrhythmia, it has to be given. Now, 48-year-old man who present with acute MI complicated within first 6 hours by ventricle fibrillation. No, the indication is post MI. Post MI, it is given after 40 days. After 40 days. So, and ejection fraction should be less than 35% post MI. So within 6 hours, it is not given. So we have to wait for the 40 days and ejection fraction remains low, heart remains stretched, though more chances of ventricular arrhythmia will be there. So it will be given in patients like D option. 6 months post MI and ejection fraction was 28%. It will not be, it will be given in that scenario. While C option is the indication for artificial pacemaker. Artificial pacemaker. This will be given. So answer is D option. While the other indications besides idiopathic ventricle tachycardia post MI, it will be given if there is a high risk of SCD. In cases of structural heart disease like HOCM, ARVD, or in cases of non-structural heart disease like Brugada syndrome. Brugada syndrome. So these are other indication for putting the implantable cardiac defibrillator devices. Now come to question number 14. So question number 14 is on acid-base balance. So these are the parameters which are given to you, and these are again very simple questions. But you should know the normal value of the pH. Normal pH value is for calculation purpose 7.40. For CO2 it is 40, and for bicarbonate it is 24. So if pH and CO2 are going in same direction, it is metabolic. They are going opposite, it is respiratory. So let's see, pH is going in a downward direction, but CO2 is going in a upward direction. So this is a respiratory pathology, very simple. And based on the pH, low pH is there. So this is respiratory acidosis, simple. Now, coming to question number 15. Question is, a 35-year-old woman presents with complaint of muscle stiffness and cramps. On examination, Trousey sign is positive, Chvostek sign is positive. Lab test reveals a serum calcium of 7.5. So calcium is low and phosphorus level is low normal side. Which of the following vitamin deficiency is likely responsible for this patient symptom? Why not option C in pacemaker? Option C is an indication of artificial pacemaker. It is artificial pacemaker, not ICD, not ICD. Now coming to the question. So patient has low calcium level. Low calcium level is due to vitamin D deficiency, straightforward. B12 deficiency, it causes neurological abnormalities, but not low calcium, and it causes macrocytic anemia. Subacute combined degeneration of the cord. Vitamin D deficiency, it causes perifollicular hemorrhages along with scurvy. That will be very easy. And vitamin E deficiency, it might lead to Friedreich's ataxia. So these are the nutritional based questions or deficiency related questions. So this was the mini test series, and I have picked only the high yielding topics. And when you give exam, after the exam, then you will realize that all the topics will come from these 15 questions that we have discussed. So all the very best to you. And if there is any questions, doubts, you can put in the DAMS Telegram group. So question number 13. Why can't B be the answer? So let me see what is the 13 question. 13 question is acute MI within 6 hours. No, within 6 hours, we will not give ICD device. We will not give. It is only after 40 days that there is a indication. So all the very best for your exams. And in these last few weeks, you should only and only revise your notes. No new notes you should go through. And this is the time only for revising the high yielding topics. So once again, all the very best.